The title of his presentation today is Epidemiology of Child Psychiatric Disorders, Major Milestones and Future Directions. Frank Verhulst.
Thank you, Mario, for your introduction. Thank you, Giovanni, for inviting me. Dear audience, I have to apologize because my talk will not be as entertaining as Patrick's talk was. That's because actually the editor of the former editor of the Dutch Journal of Medicine said epidemiology is nothing but counting noses, and epidemiology can be pretty dull. So I hope you can take it before lunch. And another thing is that I won't talk about services. I will talk about epidemiology, and I want to show you that epidemiology is more than counting noses, than prevalence studies, but that it also relates to etiological studies. Is there a pointer? Is there a pointer? No pointer? Do you have a pointer? Thank you. And the right? No. Oh, okay, I click that way, yes. Thanks, I have an apple. So, actually epidemiology is the science that studies the frequency of disease. And why do we study the frequency of the disease? Because it is a way to find the factors that influence the variation in the frequency of disorders or disease. And the main goal for epidemiology is that it is a guide to prevention. I want to give you a very, very short overview of major milestone studies in epidemiology. And we have to start with the first true epidemiological study. That was a study in 1958, and not many people know about that. It's Lapousse and Monk in the United States who did the first true epidemiological study. But since then, a lot of studies were being done, and there has been a development over the last years from mostly descriptive cross-sectional studies in the 1960s to the current large-scale prospective cohort studies that now integrate biological measures and use multi-informant behavioral assessments that are much more complicated than the studies that were started in the 60s. This is an overview, and actually it's a selection that I made with a co-worker of mine, Henning Thiemeyer. He is an epidemiologist, and this will be published soon in the European Child and Adolescent Psychiatry Journal. This is a selection of what I think are the major milestone studies in epidemiology. And I don't have time to cover all of them. I just want to pick out only a few. Of course, the Isle of Wight study is a major study done by Michael Rudder, famous for its first prevalence rates that were published, and famous for the showing of the gap between the proportion of children who are disordered versus the proportion of children who truly receive help. And the third part was that they showed the huge discrepancy between information from parents and teachers. So I think this is a key study. And another key study is, of course, the Dunedin study that is well famous for its longitudinal approach. It is a small cohort study, actually, but it's famous for its huge retention rate. So they still have 90% of the participants still in. And of course, you are all familiar with the gene by environment interaction studies being done within the Dunedin. A somewhat less famous study is the Christchurch study, which by David Ferguson, which also I think is a very important study in terms of the outcomes of sexual abuse and suicide in adolescents. There are a number of studies focused on antisocial behavior, such as the Montreal longitudinal study by Richard Tremblay and the Pittsburgh Youth study by, I forgot his name. I want to focus on the more recent studies, and I apologize that I pick out my own study, or our own study, that is Generation R, and you mentioned that already, and to use Generation R as an example of how we can do etiological studies in these current days. And again, I think these studies are important for finding the causes of child psychopathology, and I also want to show you that it's very difficult to find the true causes. So it's called Generation R. The R is for Rotterdam, and the aims are to prospectively measure fetal growth and intrauterine influences on later child behavior and emotional problems. And I just also want to show you, because this is about young adulthood, that this is also the foundation of psychopathology also for later ages, and to understand the mechanisms involved in the influence of early postnatal factors to child behavior and emotional problems and cognitive problems. And as our cohort starts getting older, the eldest children are now 12, 13 years, we move into adolescence, and hopefully we get enough funding to follow this cohort up into young adulthood. The study actually was inspired by Barker's hypothesis, and you're probably familiar with Barker's hypothesis. He did a very simple but very important observation, is that the birth weight is associated with the length of life. It's all about the fetal growth, fetal mechanisms, and fetal programming for later bad health, or both physical and mental health. So we started about 12, 13 years ago, the Generation R study, which is a prospective cohort study. We included about 10,000 mothers who were pregnant. Within the Generation R cohort, there is what we call focus cohort of 1,000 mothers, in which we did more in-depth assessments. And these 1,000 mothers were all Caucasian. All 4 grandparents needed to be born in the Netherlands, and that was because we wanted to have a genetically homogeneous cohort. This is what I call my bragging slide. It's just to show that we measured pre-birth but also post-birth many factors. And as you see, we did psychiatric interviews in the focus cohort. We had research center visits looking at, for instance, the attachment between mother and child and father and child. We did home visits where we looked at the father-child interaction. We interviewed all the children aged 6 using the Berkeley Puppet interview. And at the moment we are seeing the children again in the research center in the Sophia Children's Hospital, where we also do neuroimaging of the children. So I'll pick out just as an example and to illustrate a number of epidemiological aspects. I just pick out a number of findings that we have, and the ones that are gray are findings that we have published them, but I won't talk about that. So let's first talk about a very fundamental thing, is that is maternal stress during pregnancy related to later child outcomes. And as you see, and you can see that here, that depressive symptoms in the mother is negatively associated with the head growth of the fetus in utero. The same holds true for anxiety symptoms of the mother, indicating that maternal stress does influence or is associated with fetal growth. And here you see the growth trajectories of mothers without any symptoms, mothers with family stress, and mothers with depressive symptoms. And this is the fetal growth of this is not the fetal head growth, but the total body weight. And you can see that mothers who are depressed have a slightly compromised growth of the child. So although it is statistically significant, the effects are very minute. It also depends a lot on the standard deviation of the growth, and for instance, the standard deviation of the head growth is very small, so even small difference can make a difference in terms of the functioning of the child. So although we found that there is a relationship between maternal stress and child growth, we were interested in whether child growth is associated with later child functioning. And we found that there actually is very little indication of an association between the intrauterine growth of the child and later temperamental difficulties in these infants, if we controlled for a number of what we call confounding factors. That is, genetic and socioeconomic status related factors that were used as to control for the fact that these factors have an influence on the risk factor, both on the risk factor and on the outcome. So now let's look at maternal distress and postnatal child behavior. We found that prenatal depression in mothers, but also in fathers, are associated with child problem behavior. And already the fact that it's both mothers and fathers already is an indication that it's not so much the effect of stress on the intrauterine environment, but that it may be related to other factors that mediate the association between psychological symptoms in the mothers and later child behavior. And that is what we found, that the association between prenatal depression of the mother and the father and later child behavior could be accounted for by postnatal parental hostility. So it's not so much the intrauterine environment, it is the fact that mothers who are hostile, they're hostile prenatally, but they're also hostile postnatally, and it's especially this postnatal behavior of the mothers that is influencing child behavior. And this is another part of the study that shows the same. This is the level of family stress during pregnancy. Here we looked in a laboratory setting in the focus cohort at committed compliance of the child. So we had children play in the room, make a lot of mess, and then mothers asking the child to clean the mess. And there are a lot of children, who do as their mothers say, but a lot of children also, they resisted and they didn't want to do that. And we found that the higher the level of family stress during pregnancy, the less committed compliance of the child. So a lot of stress was associated with children who are poorly committed to doing what their mothers told them to do. However, this actually is you could speculate that this is due to prenatal family stress, but in fact, it is the maternal positive discipline that is mediating this association. So it was not so much the prenatal factor that was associated with the postnatal outcome, but it is mediated by maternal and paternal way of interacting with the child, which is, I think, important also for care. So we concluded that indeed prenatal psychological stress is associated with fetal development. However, fetal development does not influence child behavior, fetal growth, and that prenatal depression is associated with child behavior through parental hostility postnatally. So prenatal family stress may indirectly affect child development through what we call spillover of prenatal stress on parenting behavior. So mothers who are depressed and who are hostile, they are influencing the prenatal environment, but they're also the mothers who interact with the child in a hostile way postnatally. Now another example, an example of confounding, is maternal smoking. So the question is whether maternal smoking is harming the mother or the fetus. And we looked at the effects or the association between smoking and fetal growth through ultrasound measurements. And this is what we found. So these are the mothers who never smoked. These are the mothers who quit smoking when they knew they were pregnant. And these are the mothers who continued smoking. And as you see that the mothers who continued smoking through pregnancy had children with smaller heads compared to the mothers who quit smoking and the mothers who never smoked. Now we were interested in whether smoking was associated with later child problem behavior, and we found that if mothers smoked, indeed there was a 2 times higher probability that the children had higher CBCL total problem scores, which is an indication of problem behavior. However, the same held true for fathers who smoked. So this is already an indication that it's not so much the prenatal environment, but there are factors associated with mothers smoking during pregnancy other than the direct intrauterine influence. And that is what we found. So if we corrected for confounding factors such as alcohol use, low education, we found that the association that was significant here was not significant anymore. So indicating that it's not so much the direct effect of smoking on the fetus, but that there are factors associated with smoking. So you can use smoking as a kind of a marker. So if a mother smokes during pregnancy, it is a marker that there will be something wrong with the development of the child, but it's not so much due to the fact that smoke is bad. I'm not advocating smoking during pregnancy, but I'm just saying that it's not an easy association between the two. Another thing that we looked at was the use of antidepressants, especially SSRIs, during pregnancy. And we found that mothers who are depressed have children with lower fetal weight. However, mothers who used SSRIs also had children with smaller heads. Mothers with depressive symptoms had children with smaller heads. But the association was much larger for mothers who used SSRIs. So the dilemma for the clinician is that both mothers who are depressed and mothers who use SSRIs have a child with a smaller, have a child with smaller fetal head growth. So this is a dilemma because not treating, of course, a mother is bad for the mother, but also for the child. But treating a mother with SSRIs is also bad for the fetal growth. And we also looked at brain structure and MRI, structural MRI later in life, and we found the same relationship over the years. So SSRI use has risks for the developing child. Now, for time's sake, I skip a lot. Now let's not look at something biological, but something environmental that we studied, and it is the influence of ethnicity. Rotterdam is a multi-ethnic population with a lot of nationalities, and we looked at the level of problem behaviors in children in the Generation R study, and we found that children from non-Western ethnicities or cultures, they all had higher levels of problems compared to the Dutch children and to the European immigrant children. No, sorry, only to the Dutch children. So all immigrant groups had higher problem scores. Now, the question is that due to the ethnicity or due to other factors? And we looked at a number of risk factors such as poverty, not speaking Dutch, migration over 15 years of the parents, the feeling of being discriminated, poor education, and level of psychopathology in mothers. And what we found was that if immigrant children had no or little risk factors, their level of problems was comparable to the level of problems in the Dutch children. Whereas if the number of risk factors increase, you see that the probability of the child having high levels of problems is much greater. So it's not so much the ethnicity, but it's the associated risk factors that are responsible for the higher level of problems, which would also hold true for the Dutch children. If their parents have a lot of risk factors, their level of problem behaviors will also be increased. So what's one of our other research lines within Generation R is to look at economic disadvantage, and you won't be able to read all this slide, but we looked at, we did home visits when the children were a few months old, and we looked at how economic deprivation is associated with child externalizing and internalizing behavior at the age of 3 years. And we found that this association is mediated by maternal depressive symptoms and especially harsh disciplining. So again, it is the parental behavior towards the child which is much more influential than a lot of biological factors that we're interested in. So we looked at attachment just to show you what we're doing and what we did. We looked at attachment when the children were 10 months old. We looked at mother-child interaction and father-child interaction at ages 3 and 4. we look. This is the committed compliance. So this is the mother asking the child to clean up. He doesn't, and we looked at heart rate and aggression. For instance, we looked at lying. Children were being told that they were not allowed to open a box with a nice thing in it, and of course a lot of children couldn't do that, so they opened the box, and then later we asked them, did you open the box? And some of them said yes, and others said no. And so we also looked at what the effects of what lying indicates in terms of later antisocial behavior. So for time's sakes, what have we learned from a study like Generation R? We found that, actually I was a little bit disappointed, because I thought when we started Generation R that we would find a lot of biological factors that would be associated and would be responsible for later child prone behaviors. But we found that there are a large number of factors that each contributed only to a very small degree to later child behavior, and that the relationship between biological factors and later problem behavior in children is very, very complicated, and often confounded by especially how parents act towards their children, which is, I think, maybe good news for child psychiatrists, because there is the arena where we can intervene. So we adhere what is called a cumulative risk model, where we look at multiple risks that are additive or that interact. They do that, and as you know, the more risk there is, of course, the higher the probability that the child will have psychopathology. However, if we look through all the data that we have, and a lot of publication, that the most prominent factor that we found is actually parental behavior. So parental behavior, especially hostility, pops up again and again, and we're looking, we're imaging, we're looking at cortisol, whatever. It's parental behavior that is still popping up as the strongest negative factor over time, and not only of the mothers, but don't forget the fathers. They also have an influence. So, in terms of methodology, we learned a lot over the last few years, not only in our study, but also in what we call our sister study, ALSPEC, in the UK, where we collaborate with. There are a lot of replication studies being done crossover, so from ALSPEC to Generation R, from Generation R to ALSPEC. We've learned a lot about confounding factors and causal inference. We always thought that if you do a longitudinal cohort study starting early in life, you unravel the causal mechanisms. But still, in a study like this, it's very difficult to tease apart whether child behavior or parental behavior is the cause of child prone behavior, or vice versa, and to what degree child prone behavior is influencing parental psychopathology, reverse causality. Shared method variance bias. So a mother who is depressed giving information about the child behavior is very, very much biased, and you need multiple informants. So you need maternal reports about her own, but then, for instance, paternal or teacher or children's self-report information about their functioning. Also, we used a lot of observational aspects in Generation R, where we try to have more objective measures of child or mother and child or father and child interaction. Replication is very important. So having another cohort study where we can try and replicate studies. And then, of course, selection bias is an important worry in longitudinal research, where you lose children longitudinally. So I wrap up, and what are, since 1958, the first epidemiological study, what are the successes of epidemiology? I think one of the successes is the prevalence, the frequency, and the course of child psychiatric problems. I didn't talk about that, but child psychiatric problems are pretty persistent, and you will talk about it later. You will talk about it, sorry. I think another success of epidemiology is that it showed the strong association between social disadvantage and child treatment with later behavioral emotional development. I think that is there's a causative relationship there is pretty much evident. However, I think we should also say that there are failures. And one of the biggest failures, I think, in epidemiology over the last 20 years, 10 years, is that we had high expectations that biological factors, biomarkers, candidate genes, candidate gene by environment interaction, GWAS, we had hoped that these things could better explain and diagnose and predict child psychiatric problems, but these high expectations have not been met. For instance, the expectations of candidate gene by environment interaction studies, starting with the Caspi and Moffat articles in Dunedin about 5-HTT and MAO-A by environment interaction. People are very skeptical about to what degree this could have been replicated, and some people say that most of these findings are chance findings. So I think to apply genetics, neuroscience, and other molecular research to better understand how the brain produces maladaptive behavior, I think we need to conduct more ambitious, large-scale child psychiatric cohort studies. And we need to pool different studies that have same or similar methodologies across multiple sites. I think that is a major challenge for the future. I thank you for your attendance. I hope I didn't bore you too much with a more research-oriented presentation. I also hope to show you that studies like these cohort studies can give information also, if we wait a little longer, on the transition from childhood or adolescence into young adulthood, and that we need very complicated methodologies to try to tease apart cause and effect. Thank you very much.